Connie. And I'd like to, on the behalf of the Remember team, I'd like to thank the organizers for inviting us to present our results as a late breaker, and also thank the audience for coming to our session. So the title of my talk is a bit of a spoiler alert, but I'll proceed to tell you about our study. Essentially, early mortality and morbidity within the ART programs has remained a significant problem in resource-limited settings. And as we just heard, TB is a major cause of early morbidity and mortality, even in the ART era. This sets the background for why we initiated this study. Here is a systematic review of the mortality outcomes at 12 months across a variety of cohorts in resource-limited settings. And we can see here that in sub-Saharan Africa, the mortality estimate is 17%, slightly lower in other regions of the world. Also, if we look at the mortality in sub-Saharan Africa and compare that to mortality rates in Europe and North America, we can see there is a large gap in the mortality in sub-Saharan Africa versus Europe and North America, and that it varies significantly by CD4 count, with the highest mortality occurring in those with the lowest CD4 counts. We also know that the incidence of TB after the initiation of ART can be very high, and that TB can be difficult to diagnose due to the limited diagnostic assays, particularly in those with advanced disease. And as TB diagnostics are evolving, they have not been widely implemented, and there are issues with their sensitivity, specificity, access, cost, and implementation. Therefore, we proposed the hypothesis that empiric TB treatment would be associated with a decreased risk of death compared to the standard approach among participants with advanced HIV at high risk for mortality in resource-limited settings. The Remember study is a phase 4 open-label strategy trial that took HIV-infected adults with a CD4 count less than 50 cells and no active tuberculosis and randomized them to one of two arms. One was antiretrovirals plus 4-drug empiric TB treatment, called the empiric arm, and the other was ART plus IPT. And TB therapy would be given if they were diagnosed with TB during follow-up, and this is the IPT arm. ART was initiated in 3 days of randomization, and TB treatment was initiated within 7 days. These are our eligibility criteria for our study. Specifically, we did require that the CD4 count be below 50 cells, and we wanted to exclude active or suspected TB. We stratified the trial according to having a CD4 count above or below 25 cells, and we also looked at poor prognostic factors, having none versus at least one of recent hospitalization, low BMI, or anemia. Over the course of this study, we did have some evolution in our screening guidelines. Initially, we conducted a TB symptom screen, targeted exam, and sites were allowed to perform additional evaluations per the standard of care. At approximately halfway in the enrollment, as expert was rolling out, all sites were required to do an expert examination through the screening and also send for culture. Our study regimen, the empiric TB arm, was a standard fixed-dose 4-drug regimen for 8 weeks and then 2 drugs for 16 weeks, and the IPT arm was 300 milligrams once a day for 24 weeks. Both arms received efavirenz-based therapy with Truvada, and if they could not take Truvada, locally available 2-drug NRTIs could be taken. The primary objective was to compare survival probability between the two study arms after randomization, and the primary endpoint is death or unknown status at 24 weeks. We also evaluated several secondary objectives, including time to death, time to AIDS progression or death, and the rates of safety and tolerability and TB incidence. Our primary analysis is intent to treat. We use the Kaplan-Meier estimator to estimate the primary event rates for both arms, and the z-test was used to compare the primary events between the arms. Here's our CONSORT diagram. We screened 1,368 participants and excluded 578. 33% were excluded because they had a CD4 count above 50. 31% had active TB disease or suspected TB disease. 15% had labs out of range, and 20% had a variety of other reasons for their exclusion. 850 patients were enrolled, of which 424 were on the empiric arm and 426 on the IPT arm. These are the baseline characteristics of the 850 enrolled participants. You can see that there is good balance across the arms, and I would like to highlight that the participants enrolled were highly immunosuppressed, with a CD4 count median of 18 and 19 in each arm, with just over 60% of the patients having CD4 counts less than 25. We enrolled in 18 sites in 10 countries, with the majority of patients being from Malawi, South Africa, and Kenya. And here are primary endpoint results. Essentially, we had the exact same number of endpoints in the empiric arm and the IPT arm, and a very low mortality rate of 5.3 and 5.2% in each of the arms. The absolute risk difference was minus 0.06%. If we look at time to the primary endpoint, we can see that the two lines essentially overlap entirely, and there is no difference between the arms. In our sensitivity analysis, looking at our stratification factors, again, we see that there is no difference between the two arms with respect to whether a sputum was conducted for expert or not, whether the CD4 count was below 25 or above 25, and there's also no difference between the arms according to whether poor prognostic factors were present. Our causes of death were primarily HIV infection or HIV-related diagnoses. Our time to death or AIDS progression was more rapid in the empiric arm. However, this did not achieve statistical significance, and it appears to be entirely fueled by the time to confirmed or probable TB, in which there were more cases of tuberculosis in the empiric arm, and it began to diverge from even the 2-week time point. Here's a description of our incident TB cases. We had 33 TB cases that were externally verified in the empiric arm and 19 in the IPT arm, and the majority of the diagnoses were extrapulmonary TB made on clinical grounds. Our secondary outcomes at 24 weeks, you can see that virologic suppression was essentially equal between the arms. The median change in CD4 count was also the same. Toxicity, as determined by grade 3 or 4, signs, symptoms, or laboratories were equal between the arms, and new diagnoses were common, occurring in approximately 50% of the participants in both arms. TB iris occurred 2% in each arms. The self-reported adherence to both ART and TB drugs was similar also according to the arms at each of the different study weeks. In conclusion, empiric TB treatment did not reduce mortality at 24 weeks compared to INH. We observed a low mortality in both arms for the degree of immune suppression in this patient population. And there were no differences according to the stratification factors in either of the arms. Incident tuberculosis was more common in the empiric arm. We don't have a great explanation for this, but it may be partly explained by adherence that we have not been able to delve out of our data thus far, or possibly since we saw the divergence in TB cases occur early on, there may be more TB just by chance. Empiric TB treatment, however, did have a similar safety profile to INH. That adverse events were similar. The new HIV-related morbidities were generally similar, with the exception of TB. The virology and immunologic outcomes were also similar, and we also saw similar adherence. So our conclusion would be that the current WHO policy advocating routine TB screening and IPT use is sufficient to be able to markedly reduce mortality in a patient population at high risk for death. And there is no added benefit to empiric TB treatment in a setting of systematic TB screening. So more is not necessarily better to prevent mortality. I'd like to acknowledge the investigators of record from each of the sites, their study teams and site staff, our study participants, and our funders. And I'd love to take questions.